Good evening, everyone. This is Derek Alderson, the President of the RCS England, and I'm joined this evening by Nigel Mercer, the President of the Federation of Surgical Specialist Associations, and once again by Lucy Davis, Director of Engagement at the College, who will mastermind this evening's webinar. We thought that tonight we would try and talk about two main areas. That is the prioritization of surgical procedures that we recommend, and the way in which that might play out as you begin to carry out more surgery in coming weeks. And then we'll spend a little bit of time just talking about some of the recovery plans that we have just issued today following the release of the statement by Sir Simon Stevens on behalf of NHS England that was issued around about 5 o'clock this evening, which I think is available on the web. Can we go to the next slide, please? As you know, we've already produced quite a bit of information in relation to the crisis. I'm not going to read the slides to you. We'll spend a bit more time as we go through this evening looking at some of these issues. Next one, please. These are the guidance documents that are available for you to access on the college website as things stand at the moment. The one that I draw your attention to is down at the bottom there, and that is the guide to prioritization of surgical procedures that was originally released by us on the 11th of April. We have an updated version with NHS England now. It's been produced by Nigel Mercer on behalf of the specialist associations and has been endorsed by this college and by the other three surgical colleges. Can we have the next slide, please? And I'm going to hand over to Nigel now, who's going to sort of take you through what this document was meant to try and achieve without going into the individual details. Nigel.
Derek, thank you very much indeed. This was an enormous piece of work, and thank you to all the surgeons who contributed to this in the specialty associations. So as you can see, what we were asked to do was to classify the patients who would require surgery during the COVID crisis. And we were given slightly arbitrary timeframes to look at. And that was in 1A, less than 24 hours, i.e. an emergency. 1B, 72 hours, i.e. something which was urgent. Less than 4 weeks, less than 3 months, and then greater than 3 months. And what we asked each of the specialty associations and the other specialty associations underneath them to do was to give us a prioritizing list, which then was put together into 5 extremely large sheets, so that every specialty, including now eyes and obstetrics and gynecology, are on there, so that say a theatre manager or a local manager could say, I've got these cases that need to be done urgently. Are they on the list? Yes or no. Are they on the urgent list? Yes or no. Are they on the less than 1 month? And it would give a level playing field for every surgical patient and every procedure that we needed to do during the time of the crisis. And it was slightly dirty. It had to be done quickly. But I'm delighted to say that all the surgical specialty associations fell in behind this and have all agreed it. The updated version has got some minor changes that no major fields have been left out or had to be put in, but there are some minor changes in that, and so it should give a bit more information. And we're anticipating that being out from NHS England pretty quickly. As Derek said, it's available on the website. It's available through the NHS England website. All the colleges have contributed to it, and it's been a massive piece of altruism. Each of the fields has a procedure in it, or 2 or 3 procedures in it, but it doesn't appear under every specialty who performs that particular procedure. And so everyone's just got behind that. If you have someone who needs something doing, say if it's in the head and neck, you need abscess training, it may not be under ENT or Max Fac, it may be under somewhere else, but it will be there, I promise you that. Any questions about that, I'd be delighted to take them at any stage. You can always email me through the FSSA and we can pick those up as well.
One of the things we didn't do, Nigel, is to, as it were, try and sort out the bun fight between specialties when a particular procedure appears at the same level of priority. Maybe you could just tell everyone about how we think that sort of debate needs to be handled when two different competing specialties find themselves each with a patient on the same page and only one theatre slot.
Well, in that situation, it would be down to, is it threat to life? The person who has threat to life goes first. If it's, and they're salvageable. If it's then below that, then I think there has to be a grown-up discussion between all involved. And a lot of these situations, the anaesthetist who's running the list for that day will also have to have a say in what's going on and may have to wield the sword of Damocles over people. But I'm not hearing anyone having major problems about prioritising procedures. I think everyone has been fantastic and has really played this game incredibly well, Derek. It's not something which has come to my ear.
Good. Okay, can we go to the next slide, please? So, as most of you will be aware, in the local press in recent days, there's been quite a bit written about the idea that now that the number of COVID new patients is beginning to fall, that there is the emergence of some spare capacity in our hospitals, and that we should be preparing ourselves for the reintroduction of that urgent surgery that has been postponed, but perhaps more importantly, a resumption of some types of elective surgery. And of course, one has to accept that some specialist hospitals and the nature of services means that this will be quite a variable feast. And of course, the level of COVID within a specific geographical area will also be varying, and the rate of fall will be changing. So the point at which this activity starts to take off will vary by region in the United Kingdom. But having said that, there are many considerations in order to bring surgical work back in this way in a sensible fashion without adding risk to our patients, risk to ourselves as staff, and also how to ensure that patients are dealt with fairly and equitably for this. So we've just released today some guidance on this. It covers 9 themes. I've shown you the first 4 themes here about the kinds of general issues that need to be considered as surgery is progressively reintroduced within your institution or in your geography. I'm not going to read the slides to you. You can all read. Maybe I'll just pick out 1 or 2 specific issues. One of the important things, obviously, is hospital capacity and the workforce that we need in order to deliver the backlog of relatively urgent surgery that has been, let's say, postponed over the last month or so. We do believe that there will be a need to retain some services in independent sector facilities in order to be able to expand the work. It will probably not be possible to expand our commitments using only our traditional NHS facilities. One other thing that is being considered is the possibility of retaining some of the proposed Nightingale units as the hospitals that will deal with the COVID positive patients in order to create COVID negative or COVID free zones or buildings within our NHS facilities or at independent hospitals that would allow us to return to more surgery. Can we have the next slide, please? Obviously, in order to do that, we have to retain many people who have returned to work. They must see this next phase as just the next part of the crisis. It's, I think, what the CMO has called some of the indirect effects of COVID. I think that obviously for the surgical community ourselves, we have to appreciate that the length of time or the duration in a working week that we are able to spend in an operating theatre probably ought to increase. And that will mean some modification to people's work plans and job plans. And perhaps one wouldn't wish to see that become the first priority, but perhaps it ought to be understood that a negotiation would have to take place at some time in the future in order that you should have a proper job plan. We have to, of course, consider how do we continue to train as well as we can if we have to work on more than one site with potentially expanded facilities. All of this, of course, will have to go alongside the continued need to operate on patients who are COVID positive in an emergency or urgent situation. It gets really complex when you think of how we deal with some of the more complex yet urgent surgery that's been held in abeyance, particularly cancer surgery, in the last month. And I don't want to try and play down the complexity of all of that, where we need considerable infrastructure to deliver those surgical services, bearing in mind that our intensivists, our anaesthetists, and many of our theatre and ward staff are pretty worn out as a result of the extra commitments that they've been making in dealing with the COVID positive population. So there's a lot to be done. Many agencies are involved. We're working very closely with NHS England in order to try and see how this might be brought in best. Already, I'm aware that some specialist associations have begun to produce their own advice to their own members in that regard. Of course, once that happens, you'll start to see some small differences, but we shouldn't allow subtle differences in approach to deflect us from a general plan about how best to go about this. So that's enough of me rabbiting on, as they say. You don't want to just listen to me give you a lecture all evening. We've had quite a few questions ahead of tonight, which came in over the last few days. Lucy, I think, has selected the ones that sort of came out on a regular basis, and then we'll take questions as we usually do as they come in hot this evening, and do our very best to answer them. If I can't answer them, I now have an able assistant in Mr. Mercer, so he's pleased. Lucy.
Okay, so the first question we've got this evening is, when should we be reintroducing a lap elective colorectal resection? Should we ever have stopped doing it?
Yeah, this is a difficult question to answer in a kind of straight way without sounding as if I'm sitting on a fence. I'm well aware that the Association of Laparoscopic Surgeons of Great Britain and Ireland have come out with a fairly strong statement about the value of laparoscopic surgery. And I have to say that the statement that they put out seems entirely reasonable and entirely logical to somebody who used to do a lot of laparoscopic surgery like myself. One has to accept that there are at least some theoretic risks associated with laparoscopic surgery, but on the other hand, I think one has to equally accept that appendectomy in a morbidly obese patient may have substantially greater advantages to that individual if done laparoscopically than a big open operation with all of its attendant risks. So there is an issue here, very strongly one of judgment by the surgeon. Your experience with that particular procedure is clearly an important issue. As long as, of course, the surgeon is appropriately protected and the surgical team are appropriately protected, then I don't see any reason why some laparoscopic surgery should not be undertaken by a responsible surgeon in an appropriate circumstance.
Can I comment on that, Derek? I think I agree with that. Also, over the last month or so, there has been an enormous change in how procedures have been done, and there's been a lot of good practice which has come forward, and people have understood more about problems. But about a month ago, we were hearing about explosive detonation of the uterus from the vagina because of the pressures not being equalized before stopping a laparoscopic procedure. And we have to remember this, just members of this college who do laparoscopic procedures. And the paramount thing is to make sure the patient's not being put at risk. They understand the additional risks of either procedures, either open or laparoscopic, and that you're not being a maverick, you're not putting the rest of the theatre team at risk.
Yeah. Yep. I mean, for most patients, I suspect that the risk-benefit equation is not that complicated to work out on an individual patient basis. If the risk-benefit equation is a difficult one, then a discussion with the patient and the rest of the team probably can resolve the vast majority. Okay, Lucy, next.
Okay, so we've got a question from one of our members in India. If we don't have a facility of negative pressure theatre and we only have laminar airflow operating rooms, do you recommend keeping the laminar airflow on?
This is a tricky question too when you talk about the theory. Now, I'm not an expert on operating theatre design and airflows, but I have heard about this issue before, and it's an issue that was raised by the college with Public Health England about a month ago, when it was felt that perhaps switching theatre ventilation systems off would be beneficial. The advice that we've been given is that theatre ventilation systems should stay on in that context, because the risk of nosocomial infection with theatre systems switched off exceeds the COVID risk. So the advice, I think, at the moment is theatre ventilation systems should remain on. The bit that gets tricky is when you start to find out how fast is the air being recirculated in your particular operating environment. You know, when was the system put in? What sort of ventilation or exhausting system is in use? Where are the filters in your system? Where is that air actually going after it's been in your operating theatre? In many modern hospitals, air conditioning systems are redirecting the air throughout the system, but with filters in them. So there's a little bit of local knowledge that becomes necessary in order to answer the question about air circulation and theatre pressurizing systems. But in general, the advice is keep it on.
And 7 changes of air, I believe, is recommended.
Yeah.
Okay. In emergency surgery, say on the fracture neck of a femur in an elderly, do you recommend RT-PCR testing preoperatively if the patient has no symptoms of COVID-19?
Yeah, I mean, I still think that if you're talking about urgent and emergency patients who come in, therefore, via a largely unselected route, our strong advice has to be that you should always consider those patients as being potentially positive. We're very familiar now that there's an asymptomatic phase. There's obviously the issue of the elderly perhaps coming from an environment where there's a high risk, like a nursing home. So I think that you have to consider the patient to be positive till you've proven otherwise. Now, the issue then is how do you try and prove that the patient is unlikely to have COVID carriage? There's a bit of history that might be very helpful. There's the possibility of antigen testing, and if you can get the test result back promptly before the need to do surgery, well, it clearly is important, because a positive result means a lot. A negative result doesn't mean very much. You've got to accept that you'll have probably a false negative result in a person who's at the early stages of disease in maybe as much as 20% of patients. But a positive result means a lot. So assume the patient is positive. If there's time and you can get a result back in time, definitely I think that you should proceed with antigen testing.
Again, can I come in there? I think when we're looking into the recovery phase, the increased need for testing, if you look at what's happening in Korea, the other countries which are on the other side of the curve from us, testing has been absolutely fundamental for patients and for staff in the facilities to keep them COVID free. And I think that certainly the college has been, and the FSSA, all the colleges have been making the point about we need to have better testing.
Yes.
To make sure.
Absolutely. So, of course, patients and staff should be tested. And the issues really are, if a patient, let's deal with patients first. For the patient, the issue then is when you've tested the patient and shown that they have a negative test, what measures should you then be willing to put in order for that patient to undergo surgery in what's perceived to be a COVID-free environment? In other words, what type of isolation do you believe is reasonable over what period of time before the patient can undergo surgery? As far as the staff goes, the same thing applies, but it's a case of how often do you test and retest your staff in order to have some reasonable assurance that the staff themselves are also not in that asymptomatic phase. Obviously, it's different for patients who have symptoms. That's a different issue entirely. But it's the issue of unsuspected carriage at the outset of COVID infection.
Okay, thank you. So can the college clarify an acceptable preoperative process to screen patients having elective/urgent surgery to minimise their risk of having a general anaesthetic whilst unknowingly having a low-grade COVID infection or being in the early stages of an infection?
Yeah, well, I mean, that's exactly what I just was talking about. Yes, you must have, before you can expand surgery beyond doing just emergency and very urgent stuff, you have to have appropriate testing facilities in place. I think that's an absolute given. If you can't get test results back promptly, then the whole thing of expanding surgery, I just don't see how it works. For some types of surgery where pulmonary complications are perhaps particularly prevalent, so that's mainly obviously chest surgery and gastrointestinal surgery, some consideration clearly should be given to CT scanning the chest of those patients. Now that's fairly straightforward. If you think about the types of abdominal surgery that is relatively urgent or time dependent, most of that surgery, the patients are going to have a CT scan of their abdomen for diagnostic reasons anyway. And the basic premise, therefore, is if you had requested a CT of the abdomen on somebody who's likely to need a major laparotomy, then get a CT of the chest as well for those patients, because it doesn't add very much, but it does give you some additional information about their pulmonary status at that point in time.
There's some Barts have got an interesting SOP with their cardiothoracic team, where they've shown, I think, in about the last 100 patients, by adding in that CT scan of the chest before doing anything to the chest, they've reduced the risk of post-operative complications and COVID to a very, very small figure. It's almost zero. And
Yeah.
also we have to remember a lot of patients who are waiting for cancer will have staging CTs. The thing to do is not do the staging CT a month before the operation, but maybe move it a week before the operation. So you know if they've got changes. But the other thing is, if they've got changes, they need the operation. You've got to have those discussions, because Montgomery still applies. You've got to put them through the mill in terms of what their choices are and record it all, I'm afraid.
Yeah. And sadly, although there's an implication that major surgery on COVID positive patients is associated with significantly worse outcomes, we don't have good evidence from Western Europe yet on exactly what the magnitude of that increase, if indeed there is a significant increase, what the magnitude of that increase is. So it's difficult to have that particular type of conversation with a patient at the moment. But I think it's entirely appropriate and it's responsible to tell patients that that uncertainty exists as we are now. We will start to get information from some of the research that's been done by various surgical groups, particularly COVID Surge in the UK, about those risks. But we don't actually have a definitive answer as yet.
The other thing to just bear in mind is that we never expect, well, we all expect every operation to go beautifully and smoothly, but there is a proportion of patients who will have quite major complications. And you have to remember that if you're doing an operation that might end up needing an intensive care bed and you haven't got one that's COVID-free, or the patient can't access post-operative facilities, physiotherapy, whatever they need, occupational therapy, which is appropriate, they don't get a good result of the operation that they would have got 8 weeks ago, and they haven't been warned, then I'm afraid we are liable as surgeons. There's quite a lot of talk about that in the legal field. So don't just think about the operation, think about what the hell happens if the wheels come off this procedure at 3 o'clock in the morning.
Yes, yeah, that's a really important point, Nigel. I mean, there's two elements, I think, is the one is, you know, do you have access to the resources that you would normally have if you get a specific complication? A post-operative bleed, do you have interventional radiology to help you? Because that's what you normally perhaps would have done in order to deal with that problem rather than subject the patient to another operation. And failure to rescue, of course, that is a significant complication occurs, perhaps a pulmonary complication that would require the patient to return to the intensive care unit and go back onto a ventilator. You have to be confident that you have the staff and, of course, that you have the ability to return that patient to the intensive care unit in a safe fashion, bearing in mind that as we expand this type of surgery, we are planning, hopefully, to be able to conduct the majority of it in a COVID-free environment. So there we are. Right, Lucy, let's...
Okay, so the pre-questions before we move on to the ones that are... Does the President have any advice on those surgeons who are effectively being furloughed in all but name due to the suspension of elective activity? How should we record, use this downtime in view of the fact that we will be needed to do extra lists in clinic once routine work restarts to catch up?
Well, I suppose the overriding thing that I'd say here more than anything else is I'm not aware of large numbers of surgeons sitting around idly doing nothing. I am aware of many surgeons going more than just the extra mile at the moment, who are doing almost superhuman efforts in areas that they're not familiar with, but who've managed to get themselves a bit of retraining and taken on quite different roles from normal in order to help in the current crisis. And, you know, I admire each and every one of those people for the commitment they're making to do that. So I'm not really aware that there's a large number of surgeons sitting at home or pottering around in their garden. I suspect that there are lots of things that if there are such individuals, there are plenty of things that they could do to help their colleagues. We know already of many individuals who are doing video conferencing in order to, making use of what we would call telemedicine. And I think that there's lots that people can do, and there's lots of supportive jobs that you can do for your colleagues if you're in a situation where your clinical skills are not really essential at this time. But I don't think that it's a big problem, to be honest.
I agree, Derek. I haven't heard very much of it, but I think if you are in those situations, you know, the whole population by and large is being incredibly altruistic about this. So if you have felt you've had a lot of downtime, just keep that in the back of your mind when someone asks you to do some catch-up work when the time comes. And obviously, we went into this with a big problem about pensions and about waiting list initiatives, but actually the whole country is being altruistic, and maybe as surgeons, if you don't be altruistic, if you're not altruistic at the end of this, the negative press that might go with that would be shaming, completely shaming. So I think it's got to be done on an individual basis. It's down to individual consciences. But as Derek said, I know a president of an association who is running, surgical association, who is running a COVID ward at the moment, and effectively is working as a chest physician. So I don't agree with Derek. I've not heard of anyone who sat around twiddling their thumbs. Everyone is doing something to help.
Okay, Lucy.
Okay. So I'm going to give you some people's names if they've included it in their little message to you. Okay, so good evening. Should the plans to increase surgical activity also include recognition, guidance on decreasing activity should a further spike or wave of cases happen in the middle of the recovery period? And that's from Duncan, who's the president of BAUS.
Yes. Of course, that's a very real threat. And of course, there's many elements to this. It's important, I think, for the surgical community to consider all of the important steps things that you want to see in place within your trust before you launch into this idea of doing more and more planned surgery. So, you know, are you sure that you have all the interdependent services to hand before you start again? Are you sure that you've got adequate protective equipment to sustain both your new surgery, potentially in a COVID-free environment, as well as enough surgical equipment and personnel to maintain your COVID-positive service? You know, are the logistics in place within your own institution in order to expand surgical services? So all those things that we've put down there on that recovery plan, you have to have them kind of all, and you've got to make sure you've got a tick in just about every box in order to convince yourself that you can genuinely expand. And of course, if you start trying to cut corners, and I suspect that there will be some places where either people unwittingly don't consider everything, or people start being driven to try and do things because the neighbouring trust is doing it, you know, then we do run significant risks of having to switch off again. I think that that would be very damaging for us. I think many people are already hoping for light at the end of the tunnel and a bit of a restart. It'll take people back to where they were. I think that if we get it wrong by trying to run before we can walk, then you know, we will regret that both in the short term and in the long term. So it's a very real risk, and it's one of the reasons why I think people should think very carefully about the issues that are raised in trying to increase surgical activity as we try and start again.
I think the other thing about it is that second peak, we know what happens in the first peak, and we have to give credit to the government and NHSE. The Nightingale units haven't been used anywhere near their full capacity, and so for us, if we could move the COVID cases into the Nightingale wards and carry on in COVID-free environments in the NHS, that would work. And the same with the private hospitals. A lot of them have been very underused during this, but you know, we have had fantastic capacity. And so we have got a bit of wriggle room if another spike happens, that we now understand what we would need to do next time round.
Yeah.
I hope it wouldn't have such dramatic effect upon running routine surgical services. But again, we're into the risks, problems of PPE and people falling sick and no one having a holiday, etc. And also looking after everyone's mental health is going to be a major factor.
Yeah.
Okay. So a question about any guidance on consenting or any addition of the risk of sorry. They're asking for guidance on consent.
Yes. So we are working with medical ethicists around the specific issues raised in obtaining proper consent, shared decision making nowadays we should call this, in line with Montgomery's the Montgomery ruling. We have a webinar. Lucy, you'll have to tell me. We have a webinar, I think, lined up in which we aimed to try and go through some of the ethical issues in more detail.
Yes, we do. Yes.
You can't remember
You'll have
the date.
I can't remember the date.
I'm just.
That's what happens with live. That's what happens with a live show. Not as efficient as the BBC. We can't get it to scroll on the bottom for you.
I'll step in here. I've just completed my LLM through Cardiff University. Certainly Montgomery still exists. It's still going to be in play, and certainly the lawyers will insist that must be followed. So you do have shared decision making, but then we're into the Donald Rumsfeld unknown unknowns, the known knowns, the known unknowns. And so consent does become a problem. Someone was asking me today whether or not there's going to be national consent forms for this, and the problem is it's so variable on a patient-by-patient and procedure-by-procedure basis, it's impossible. And all I would say is everyone's got to be very diligent over this, that it's got to be double recorded. You'll have a local ethics committee. If you've got a problem about consent, you can go to for advice. Obviously, if it's an emergency, then you've just got to do what any doctor would do in that situation. But the other issue here is that we've got the old form of, is it reasonable? Would any surgeon of reasonable experience perform that procedure in these circumstances? And so that will also come into play. And if you do something which is chancing your arm, or you're just going to take a bit of a gamble on doing something, the best answer there, best advice is don't do it, unless it's going to be absolutely essential to save that patient's life in an emergency, because again, that may come back to bite you. So basically the law has not changed in the last 8 weeks. It is as it was before. And there are bound to be some test cases. In terms of, I think the anaesthetists were asked if an anaesthetist switched off a ventilator to give the ventilator to someone who was survivable, would that? And the answer is that's murder. You're not allowed to do that. That the law hasn't changed over things like that. So if you're not sure, take advice from the legal department, and you have to practice here very safely.
Yeah. Okay, so the answer is the 17th of June, sorry.
Oh, 17th of June, well done. And of course, remember, there's nothing wrong with saying to patients that you do not know the answer to something.
Absolutely.
Know the answer, rather than trying to kind of guess at it. Patients do understand that there's doubt about many of the decisions that we have to make in the current crisis, in the same way there's doubt about some of the things that we've dealt with for many years. So I don't think that you should change the way in which you try and obtain consent in the current way. Do what you've normally done, and when patients ask a question that there is no clear answer to, simply tell the patient that you don't know the answer to that.
Can I make one more point about it? In terms of facilities that are available, the Health Service Act changed in 1977, and it was changed, the wording was changed very subtly. It never hit the press, but essentially the Secretary of State only has to provide a level of healthcare that's applicable to the state of the country at that time. So the fact that 8 weeks ago we provide first-rate services, nothing, everything ran smoothly, 8 weeks later, the Secretary of State can only provide what he can provide at the moment.
Yeah.
Now, NHS X will be taking that into account. And again, surgeons and your surgical teams and the anaesthetists shouldn't be worrying about the fact that you can't provide the level of care you provided 8 weeks ago. That will not come home to bite people, because there's very case law behind that.
Yeah.
And someone's asked whether COVID should be mentioned as a risk in the consent process.
Yes.
Oh yes. Oh yes.
So a couple of questions about the prioritisation. I suppose one's a comment. The problem is not the urgent 1A and 1B cases, but those cancer cases where theatre space is limited within trusts.
Yes, and we're well aware of that, and you know, so the things that are on that, let's take the sheet of procedures that can be deferred for up to 1 month. One has to accept that within a large group of patients, if you look across the United Kingdom, there must be some patients whose condition does deteriorate during that time. We have to accept that. We all accept that on a daily basis when we deal with patients. You know that some weeks are busier than others. You know that some patients get their operations slightly more promptly than others. We have all sorts of reasons sometimes why there might be a delay. All we're trying to say is if you use the guidance in this way, it will minimize the number of problems. And it tries to create a sense of fairness on the basis of clinical priority across all surgical specialties, including, as Nigel says, gynecology and ophthalmology. So if there's limited space, limited resources, limited numbers of teams available to deliver surgery, then the real thing is there has to be an intelligent adult conversation between the clinicians involved in the care of those patients and the managers to work out how much resource do we have and how do we best use it over the period that has to be considered. So it's not the case that we should, as it were, try and say, oh, well, if a patient has cancer, they have priority over someone else. That's not always going to be the case. The patients that are on the same sheet should have individual factors considered in order to reach the right decision.
The other thing about the situation we're in at the moment is that before we went into this, if you couldn't provide a service, you had a legal responsibility to refer the patient on to someone else if you couldn't do it within the waiting list times. And that wasn't used very frequently. But if, for example, in the situation that the question's about, if you know the trust, 4 miles away has got spare capacity, refer the patient there. They are the NHS's patient. They're not our patients. And it may mean that we have to put patients moving around the country more for some of the more specialist stuff. Transplant is another one, for example, that may have to be centralised. And that's work which I know Derek's been involved in higher upstream.
So one of the things that has been suggested for cancer surgery is the creation of hubs within a region or within a geographical area where you would concentrate the cancer surgery in a COVID-free environment. So it's exactly as Nigel says. You might have the situation where that operation could not take place at your traditional hospital base, but there is somewhere within a reasonable distance, by time that is, where that surgery could take place. There's quite a few logistic issues that have to be solved in doing that. Would the surgical team go there to do it? Or is it going to be referred on to another team? These kind of very simple logistic things need to be worked out. Whether or not you can do all of that, moving patients around in this way that's socially acceptable, whether or not it's possible to maintain a large cancer hospital doing lots of cancer surgery as a COVID-free environment, We really don't know until we attempt these things. But they're worthy of exploration at this stage to examine the feasibility of it. We shouldn't just say, no, that'll never work. We should look at the feasibility of it. If we can convince ourselves one way or the other, then that's absolutely fine. If we say, look, this will never work in whatever part of the world it is, that's okay. It doesn't have to be that way.
Okay, so you mentioned transplantation just before. So the categories doesn't include organ transplantation. Which category would you recommend them being placed on? It's
right.
a particular kidney at this point.
So, yes, but just to say that if you read the guidance document that accompanies, the text that accompanies directs the reader to a separate NHS website that deals with the issue of transplantation. But it has changed a little bit. Nigel, you can take it on.
There are some areas which we haven't touched on. So the prioritisation documents really are for those procedures that would be done in your average DGH university teaching hospital, that type of thing. And there are some things which are upstream of this, which right from the outset, we're going to have to be nationally sorted. And one of those is transplantation. And so that is, they're not specifically mentioned within the document. But
there is a link. The link to the appropriate website in NHSE is there.
Okay. Yep. I'm a retired surgeon and I've applied to go back to work. I have asthma, but can I help with the catch-up in a COVID-free environment?
I don't see. I mean, but far be it from me to tell somebody about what they can and can't do. But I don't see any reason why people cannot be involved. If they can get into a COVID-free environment, I don't see any reason why people cannot have clinical involvement to the level that they feel comfortable with. Now, that might be simply sitting in a room in an outpatient clinic advising trainee surgeons about decision-making with certain types of clinical problem without having to have direct patient encounters. I think most surgical trainees would think it's wonderful to have an experienced set of eyes looking at problems. People might then want to do something a little bit more. I think, again, many young surgeons would think it's enormously beneficial to have senior help doing a ward round to try and solve some clinical dilemmas, clinical situations that they are not very familiar with, that an experienced surgeon has a lot of familiarity with. Then there's the issue of assisting or doing surgery. I mean, I think that most experienced surgeons, I mean, certainly in my day, I thought it was wonderful to do an operation with another consultant because it makes life very easy. You can share some of the operation with someone without having to kind of teach constantly. So it's good. It's a good way of dealing with services. So I think there's a series of levels at which an experienced person can make a clinical contribution. And then on top of that, of course, there's all the non-clinical roles that you could do, running seminars and tutorials. Many experienced surgeons have loads of additional skills. They're very good, maybe very interested in teaching, and you can actually teach people how to teach. Some people have got a research background. They can tell people about how best to conduct the research clinical studies that they're trying to do. Other people are very good with management and leadership. So there's loads that anyone can do. And I think it's up to the individual to decide what it is that they believe would be the best use of their time, where they themselves would feel quite safe.
I could probably be a bit more strident than Derek over something like this. Surgery is a psychomotor skill, and we become rusty very quickly. And so going straight back in from being retired, even for 6 months or for a year, into the theatre environment, we're not going to be as good as we think we are or we were a year ago. But we are going to have to release. When Derek and I were appointed, Derek a long time before me, of course, we had 2.5 days in theatre. We had a day and a half a week in clinic. And there are very, very few surgeons who get 2.5 days in theatre now. Yeah. And we are going to have to get our surgeons who are in the NHS at the moment into the theatre much more often than they were. And so for retired folks, to put us into doing the clinics and running the back office is going to be terribly important. So I would agree wholeheartedly with Derek. There's definitely a role for people who have been out of clinical surgery for some time. It may not be the role you envisaged you'd be good at, but you'll be found a really good role if you decide to come back in. The answer is the water's lovely. Please come and join us.
Yes, the good news, I should say, for all the esophageal surgeons out there is that you'll be pleased to know, lads and lasses, I'm not intending to come back and start doing esophagectomy again.
Okay, should we move on? Okay, can we have some guidance on screening for both staff and patients having planned activity in green sites? How would you define a green site? Is there a minimum set criteria to qualify as a green, clean site? Can a mixed acute trust with a function ED ever be green, clean site during COVID?
Right, so there's a lot of questions in there. So there are no written absolute rules or guidance that's come out yet. I know that NHSE are working very hard on getting their guidance out soon on, you might say, criteria that identify, criteria by which a site might be identified as being a green site, COVID-free site, COVID-negative site, whatever the words are that people like to use. Of course, there's the issue of maintaining it in that way, and that is this issue that we talked about earlier of very aggressive testing of staff on a regular basis, and very aggressive testing of patients and having prompt results. I am aware that there are some institutions that can do an antigen test and get a result back within about 4 hours. And that's obviously, I suspect, not the norm, but it's achievable. And if we can reach that type of timescale where you can get results back within hours, in asymptomatic individuals who perhaps have been told to isolate beforehand, you can probably maintain a relatively COVID-free environment with a high chance that you'll be right in that way. All of that, of course, makes certain assumptions about the validity of testing and the accuracy of testing to a relatively high degree. I think that the issue for our major large hospitals with an ED that takes an unselected take of patients as well becomes much more difficult. Some trusts obviously have separate wings, separate buildings that would allow you to create a kind of COVID-free area. But of course, you would need within that designated area to, as it were, have your operating theatres, your recovery, your wards, and a fair bit of the infrastructure that the patient might need to be exposed to, like your X-ray department, that doesn't oblige the patient to have to, as it were, go through endless hospital corridors and through a COVID positive zone of that hospital on a regular basis, if that's what you're trying to create. So a block or a unit within a hospital might be achievable, but it might determine the type of surgery that could then be undertaken at that institution. In other words, if access to your X-ray department and your intensive care unit is at the opposite end of your building from your operating theatres and the place where your surgical wards are, it's going to be very difficult to create a route or a passage for those patients that doesn't expose them to significant risk. This is going to vary enormously up and down the country. Some trusts are based on more than one site, and creating a COVID-free site will be relatively easy, but some trusts have all of their resources on a single site. Some people have multiple buildings, some people have more modern purpose-built single building in which everything exists. So it will vary.
I think one of the things, it's one of the good arguments for maintaining the private sector, and the private sector is changing now. Certainly within the local one in Bristol, they're now going to be moving to do more surgical recovery work. But of course, they don't have intensive care. So they're not staffed by intensivists. They're all at the coalface, absolutely knackered. So from that point of view, it's possible. But also, you've got to remember that if you get one COVID positive patient in that place, you've got to be able to close that area of it down, deep clean it, test it, make sure it's okay, we can bring it back on stream again. So at the moment, really the only way of thinking about doing that is if the COVID patients could either go to the Nightingales and stay in the Nightingales, or whether or not we use the private sector for the full 6 months it was planned to use it for. But there's going to have to be local solutions to that, as Derek's been alluding to. It's going to be difficult. It's going to be difficult.
Yeah.
Should we try two more before we finish?
Yeah, let's do two more.
Okay. Are you or any other medical bodies have any influence on government regarding the lifting of the lockdown? I have serious concerns that we have not cleared our backlog of cancer and other urgent operations before any subsequent waves hit. In addition, we need PPE to all be optimized before any lifting.
We have no influence whatsoever in having the lockdown lifted. Nor would I seek to tell government about that. Our role as a college is to provide information to government about surgery, and if they ask us for advice, we give advice. But the decisions to actually act one way or the other is what you have a government for, and it's not for the college to tell the government about what we think about lockdown. We give advice as best as we can about surgery. That's the harsh reality of it. So I'm sorry, I don't have much influence on that.
If I can expand upon that for a moment, I think the other thing is, part of our role is to explain to patients that they've been brilliant, they've been altruistic. But there was a lot of stuff on the radio yesterday about people over 70 saying, well, why should we put up with this? And the answer is, if 1 million over 70-year-olds became ill and need to go to hospital, the hospitals would grind to a halt again. It's not about individual risk, it's about societal risk. And so I think we need to be pushing forward so that the politicians aren't saying, because we're going to start hips, we're going to start knees, we're going to start eyes. It's got to be centrally coordinated. And our job, I think, as clinicians is to highlight the potential risks that there are, and that if the lockdown is removed too quickly and we get a second spike, then we may get home a handcart again and put back things a long way. But I think the fact that our Prime Minister, poor man, has now got a new baby, having just come out of intensive care only a month ago. I mean, I think the fact that he's been at the very sharp end of this, it's highly unlikely that his view will be get rid of lockdown quickly. I can't imagine for a moment he would think that.
Yeah.
And finally, we haven't managed to answer all the questions, but let's just finish on this one. Is this not an opportunity to make a push for ring-fence elective surgical facilities permanently?
Yes, it is. But of course, it will fail to achieve ring-fenced facilities on a permanent basis, I think. You know, this gets you into things like the economics of the health service and how much of our new GDP when we emerge from this crisis is the country either able or willing to put into healthcare. Unless there was some fantastic expansion, then we will still always in a winter have to face the issue of other crises, flu, that will put demands on beds acutely. And it's very difficult, as we've all discovered, to not offer care to acutely ill patients and offer routine care to a surgical patient in place. We've not done that in the history of the health service. I agree that it's difficult, it's frustrating for surgical patients to have to turn them down. Yes, we will try our very best to expand surgical facilities, and we put forward a 5-year plan before the COVID crisis about the size of the surgical resource base, the bed base that we would need in order to deal with the backlog we had then, and to try and offer new surgery in the way that we think surgery will develop over the next 5 years and more. So yes, we're keen to push for expanded facilities with better guarantees as a result of that surgical patients will not get cancelled. But I think that the idea that we'll be able to have some mandatory statutory thing laid down that forbids all other types of patient being able to access ring-fenced facilities is a difficult issue.
Derek, I think the debate's moved on a bit from where we were, and obviously we have the girth hot cold split idea, which was if you had lights it could work. But actually we're now talking about COVID, non-COVID. We're not talking about hot cold. So we've got to focus on that, and that may mean that de facto surgery ends up having some protected beds to be able to maintain surgical services. So I don't think we throw the baby out with the bathwater on that one, but to actually say, we ring-fence surgical beds, I agree that's almost certainly never going to happen. But we've been told COVID's not going to go away. We're not going to have a vaccine for 18 months or so. So, ladies and gentlemen, for the next 2 to 3 years, we've got COVID and non-COVID sites, and that's all we're going to have.
Probably, yeah. Quite. Well, you've had tonight's double act. I think we've got 1 or 2 slides for the future. A thank you slide, and just something to whet your appetite for our forthcoming one. As you know, we do have genuine concerns about the impact of COVID on ethnic minorities, and we felt that that should be the subject of our next webinar on the 6th. Thank you very much for your attention. Thanks for the questions. We'll do our best to answer some of the questions as a group in a written response during the course of the next few days. I've quite enjoyed having a double act. It's half my workload. It's been great. Nigel, thanks very much indeed. Lucy, thank you very much. And stay safe, folks, and do your very best as usual. We're very grateful. Thank you.